First of all, I would like to thank to the scientific committee of the EASL for giving me the opportunity to give you the wrap-up of cirrhosis. Let me start with a common patient. Uh, this is Mr. John Easley, a patient with 54 years old with metal disc cirrhosis that is currently hospitalized due to acute decompensation, consisting in variceal bleeding, recurrent hepatic encephalopathy, ascites, ACLF, and is currently listed for liver transplantation. Naturally, the patient is waiting for us after the EASL meeting asking, please, doctor, is there any relevant update for me at the EASL meeting? And especially the patient is afraid about the presence of new bleeding episodes. And in this EASL meeting, there is several important findings in the context. The first is this randomized control trial performed in a unicentric setting in New Delhi, India. In this study, the investigators randomized around 300 patients with recent variceal bleeding and without hepatocellular carcinoma or portal vein thrombosis to receive a standard of care by using carvedilol and endoscopic band ligation and the association of simvastatin to the standard of care consisting, as I have said, by carvedilol and esophageal band ligation. It's important to emphasize that both groups were similar regarding etiology, child-Turcotte score and MEL score, and the authors provide analysis according to ITT population and per protocol population. It's important to emphasize that around 15% of cases did not comply with the use of simvastatin. The main endpoint of the study was 24 months all-cause mortality, and as you can see in both population intention to treat and per protocol, the addition of simvastatin was associated to a significant reduction in 24 months all-cause mortality. This effect was observed also for the development of new episodes of ascites that also were significant in both population ITT and per protocol. However, the impact of the therapy in the rest of the secondary variables, all-cause decompensation, rebleeding, hepatic encephalopathy, or development of ACLF were not significant in the ITT population, although were significant in the per protocol population. The results of this study suggest that the addition of simvastatin to carvedilol improves transplant-free survival in patients with decompensated cirrhosis with recent acute variceal bleeding. This is not surprising if we consider the pleiotropic effect of simvastatin reducing portal pressure and also stabilizing the endothelium of patients with cirrhosis. And these results agree with the BLEPS study published around 10 years ago by Juan González Arraldes, but are partially contradictory with the recent study of the Liver Hope trial, showing that the addition of simvastatin and rifaximin in patients with decompensated cirrhosis are not associated with any beneficial significant effect in those particular cohort of patients. The second study is related with the issue of sarcopenia, and the patient asked us about the presence of sarcopenia. Always, all of us are dealing with the problem of nutrition in patients with advanced liver disease. And in this context, a recent prospective study, a registry study from Italy, retrospectively analyzed a high relevant cohort of 100 patients that received tips, analyzing specifically the existence of sarcopenia in this cohort, as defined by the skeletal muscle index that you can see in the slide. Interestingly, the author shows that the presence of sarcopenia was associated with a significant deterioration of mortality, and as you can see, the 6 months of cause mortality, 12 months of cause mortality, 6 months and 12 months liver-related mortality were associated with an increase in mortality in this patient. And importantly, also, the presence of myelocetosis was not associated with any specific differences. This study also shows that the inclusion of sarcopenia in a liver-related death model that also includes creatinine and INR show an important and relevant area under the curve, suggesting the importance of sarcopenia when analyzing the impact of survival in patients who receive TIPS. And according to this study, the authors suggest that the evaluation of sarcopenia may improve the selection of adults with cirrhosis candidate to TIPS. It's important to emphasize that this study is specifically dedicated to patients with older ages, and the applicability of the results to younger patients deserves, of course, appropriate evaluation. Well, our patient, Mr. John EASL, also is very worried about the infection. Infection in patients hospitalized with cirrhosis is a common problem. And in a Spanish retrospective study performed in the recent years, the authors evaluated the possible differences in the epidemiology and outcomes of bacterial infection according to the setting of the hospital, specifically comparing the hospital with and without liver transplant programs. And importantly, as you can see in the slide, those patients who were hospitalized in centers with liver transplantation had a more frequent infection with bacteria with a greater rate of extended spectrum beta-lactamases, carbapenemases, and resistance to piperacillin tazobactam, and also with a greater incidence of spontaneous bacterial peritonitis as compared with patients hospitalized in non-liver transplant center. And importantly, in-hospital mortality was greater also in patients hospitalized in liver transplantation. Moreover, the independent predictors for in-hospital mortality were age, leukocyte count, and specifically healthcare-associated infection that plays an important role in the development of mortality in patients hospitalized for advanced liver disease. And therefore, the authors of the study demonstrate significant difference in the epidemiology and prevalence of multidrug-resistant infection among the different university hospitals, particularly between centers with and without liver transplantation. The clinical issue here is that the understanding of the epidemiology of infection in each center is crucial in the evaluation of antibiotic therapy in patients with advanced liver disease. Well, the patient also asked us about the issue of hepatic encephalopathy. The family of the patient suffers a lot when the patient had a hepatic encephalopathy. This is a common problem, and for the family, it's specifically a big challenge. Well, in this study, there are several studies that have analyzed the issue of hepatic encephalopathy in patients with very advanced liver disease. Probably one of the most important ones is this study in phase 2, dose range and randomized clinical trial evaluation, the safety and efficacy of fecal microbiome transplantation in 2 different dosification, capsular or by enema, trying to prevent encephalopathy in cirrhosis already on rifaximin and lactulose. This is a United States study. And it's important to emphasize that the authors were able to include 60 patients, and as I said before, on therapy with lactulose or rifaximin, excluding those patients with recent infections, a greater MEL score, the use of antibiotics or the existence of previous liver transplantation, and also an important issue is that the fecal microbiome transplantation come from 2 different donors. The authors randomized 4 different groups to receive baseline and after 30 days 4 different combinations of therapy, both oral and enema active, oral active and placebo enema, oral placebo or plus active enema, or both oral plus enema placebo. And importantly, the patients were similar according to baseline characteristics, specifically male, age, past history of hepatic encephalopathy, etc. The main endpoint was safety and also hepatic encephalopathy recurrence, and secondary outcomes were the incidence of other adverse events, change in infection, cirrhosis severity, etc. In this slide, you will see the most important result of the study. And as you can see, the presence of hepatic encephalopathy recurrence was significantly greater in patients who receive oral and enema placebo as compared with the 3 groups that receive fecal microbiome transplantation. And this is an important result. Related to the incidence of liver-related admission, where there was a trend to have less hospital admission after the initiation of therapy on those patients who receive active therapy as compared with patients who receive placebo therapy. And importantly, the authors developed a logistic regression model trying to evaluate the independent variables associated with hepatic encephalopathy recurrence. And as you can see, the dose number of fecal microbiome transplantation, the dose number, 1 or 2 doses of therapy, were a significant predictor of B-free of hepatic encephalopathy, suggesting the impact of this approach in the management of patients with hepatic encephalopathy. Therefore, the authors conclude that hepatic encephalopathy recurrence was significantly lower in patients who received fecal microbiome transplantation as compared with patients who received placebo. And also the second conclusion is the root, donor, and dose range did not affect hepatic encephalopathy recurrence after fecal microbiome transplantation. Another interesting study in this field was an Australian randomized control trial, also phase 2 randomized control trial, that were able to recruit 29 patients with cirrhosis and sarcopenia awaiting liver transplantation, men patients, with the characteristic of the disease that you can see in the slide. And the patients were randomized to receive a first period of 24 weeks or LPCN, an oral prodrug of testosterone or placebo, that were followed by by an open label period in which both groups were receiving the same drugs. And the primary endpoint of the study were change in skeletal muscle index, as defined as previously I have commented in other studies. And as you can see here, the most important result of this study, as you can see, those patients who received the active compound show an increase in the skeletal muscle index, a significant increase as compared with patients who received placebo, and probably most important, the incidence of over hepatic encephalopathy and the time in which the hepatic encephalopathy recurs was significantly longer in those patients who receive the active compound, and the number of hepatic encephalopathy events were significantly lower. And again, those patients who received the active compound experienced improvements in anemia, patient-reported outcome, muscle quality, 6-minute walking test, and digital Stroop test. All these results were associated with an appropriate safety profile, and as you can see, there were not significant events, adverse events in patients who receive a specific therapy or receive placebo. And therefore, the authors of this study suggest that this compound, this prodrug of testosterone, is the first therapeutic intervention that was able to improve sarcopenia and reduce hepatic encephalopathy in men with cirrhosis awaiting liver transplantation with an appropriate safety profile. Another issue that was evaluated in this EASL study is the use of rifaximin, not for the management of hepatic encephalopathy, but for the management of ascites, based on the probability, on the speculation that rifaximin may decrease the bacterial translocation and the development of inflammatory episodes. And in this large study, the authors were able to randomize 150 patients to receive rifaximin or placebo, with the main endpoint of 12 transplant-free survival, and also with evaluation of 3 and 6 month transplant-free survival. And as you can see in the slide, the addition of rifaximin to the standard medical therapy was not associated to any significant improvement in transplant-free survival, neither 3 or 6 of 12 months. And also there were no incidence or impact of the use of rifaximin in secondary endpoints as defined by infection, hepatorenal syndrome, hepatic encephalopathy, and variceal bleeding, although both therapies were similarly safe without any adverse incidence of adverse events in patients who received rifaximin. Not surprisingly, the authors of the study suggest that this phase 3 trial showed that rifaximin was well tolerated, but without any beneficial role in the transplant-free survival of the patient who received this drug. That are results very similar to those showed by the Liver Hope trial presented in this meeting the past years. Well, and the patient is in the wait list for liver transplantation, and of course, he said that if this will arrive, he will arrive soon enough to receive liver transplantation. This is an important problem because the allocation of organs is an important issue in patients with acute and chronic liver failure, and this issue was evaluated in the international study, the CHANGE study, tried to evaluate the current graft allocation policies in patients with acute and chronic liver failure. And this is international study performed in 62 liver transplantation, recruiting more than 800 patients. The authors separate the sample in 3 different groups: patient with ACLF 2-3 listed for liver transplantation, patient ACLF 2-3 not listed for liver transplantation, and patient without or with mild ACLF or MEL greater than 20 listed for liver transplantation. And the first issue in this study is that the mortality of patients not listed for transplantation suffering from acute or chronic liver failure is extremely high, confirming the result previously known. And the second important issue was that the proportion of patients who received liver transplantation was significantly lower in patients with ACLF 2 or 3 as compared with patients with a MEL score greater than 20, and that the probability of the listing rate was significantly higher in patients with acute or chronic liver failure. And importantly, this rate of the listing and death were superior in patients with acute and chronic liver failure 2 and 3 in all the different strata of MEL score, suggesting that MEL score is not able to stratify accordingly the patient with acute and chronic liver failure 2 and 3, decreasing probably the probability of survival because the liver graft is arriving very late in the natural course of the disease. Therefore, the authors conclude that this data suggests that the current allocation system are inadequate for the patient with acute and chronic liver 2 or 3, suggesting the importance of change the organ allocation system for patients with this severe disease. Well, but the patient also asked us is there any possibility that my disease can go back? And this allows us to the concept of recompensation. And an interesting and very well-designed Italian study, the authors evaluate and validate the Baveno 7 criteria of recompensation in patients with decompensated cirrhosis. And in this study, retrospective study, the authors analyzed around 700 cirrhotic patients, dividing them into different groups: compensated, 166, and decompensated, and around 300 patients would receive etiological therapy. And the authors separate the patient who receive etiological therapy into groups: recompensated according to the strict Baveno criteria that indicates that the patient should not be receiving any therapy to tell them that they are recompensated, and also with a new and extended recompensated criteria in which the patient meets all the criteria but still are on the compensation treatment consisting in low dose of diuretics, lactulose, and rifaximin. If you can see, only 4.2% of cases had the proper definition of recompensation, while around 22% of patients had the extended definition of recompensation. And in this slide, you can see the most important result of this study. The authors describe a model of survival that includes the presence of decompensation, and in a model adjusted by age, sex, MEL, albumin, varices, and further decompensation, in which the existence of recompensation was included as a time-varying covariate. And as you can see here, the probability of survival of the risk of mortality in those patients previously compensated or who obtained recompensation after Baveno criteria or recompensation after extended Baveno criteria showed a significant and non-significant difference in mortality, indicating that both ways of being recompensated had an important impact on survival, with a mortality rate similar to those patients with compensated disease. And of course, patients with decompensated C-risk had a very unmarked increase in the mortality risk as compared with patients with compensated, recompensated, or extended definition of recompensation. And the authors conclude that the Babino-Sevin recompensation criteria identified cirrhotic patients with a good prognosis comparable to that of compensated patients, and that the expanding the recompensation criteria may also identify a group of patients with a similarly low risk of mortality. And finally, our patient is now a newly happy man because he could be properly treated while waiting for liver transplantation and is now very transplanted and happy, giving us to the EASL meeting the opportunity to have new knowledge in the management of patients with advanced liver disease. Thank you very much for your attention.